Now the latest thing in the market is going deeper into biomechanics and how it impacts your judgment in choosing the right patient for refractive surgery, or on a hindsight makes you realize what went wrong in your refractive surgery. It is become extremely important to take on every possible clue, because we need to realize that iatrogenic keratosis after LVC, although the percentage is so low because of a higher understanding of the topography, it has to be kept in mind as a most dreaded complication. And this is due to the biomechanical decompensation which occurs in the corneal stroma. It could be because of a prior biomechanical weakened status of the eye, or an additive impact of the structural impact from a surgical procedure. All along, it's not that we are devoid of indicators. We did have the value of looking at the residual stromal bed thickness, and we always had a dictum that try to keep, at least leave behind 300 micron to be utterly safe, or the percentage thickness altered, that such that you do not alter the percentage thickness. I mean, should not be more than 40% at any point of time. And these detections and these values seem to be so critical. And if we keep a follow-up, I would insist that all of us do a post-op topography at least at 3 months and 4 months to have a baseline value, so that any drop in vision the patient detects, and then you do a topography, you would know that something is evolving, and then you would immediately jump to cross-link or do an intracorneal ring segment. Cynthia Roberts and Dubes came up with the understanding that actually ectasia is a focal abnormality in the corneal biomechanical properties. Again, there's a constant evolution of understanding in this, and this focal abnormality precipitates a cycle of decompensation, a cycle of localized thinning, and a further vicious cycle. And this distortion of the corneal surface generates optical aberrations and a drop in BCVA. We have the oculus pentacam, as was so beautifully brought out by Dr. Samaresh. It's a rotating Schleimpfung imaging devices which gives high resolution images, and it detects innumerable number of elevation points and captures extremely accurate resolved images to provide a detailed analysis of not just the anterior surface of the cornea, but the anterior segment, and of course most importantly the posterior corneal surface, because that is where the very early signs of ectasia are detected. So very briefly, I'm not going to these details. These are the 4 major 5 columns of understanding which you have, which tells you about the sagittal curvature details and the inferior superior asymmetry. It tells you about the elevation points. It tells you about the posterior elevation points, and it tells you about the pachymetric thickness and the thinning or the progression abnormal in one particular direction, which might clinch you to a diagnosis of keratoconus. Again, the Bellin-Ambrosius map further adds on with its 9 additional parameters and tells you based on the overall D, which is the final value, which would tell you that if it is in red, it is absolutely no for doing a refractive procedure. We were fairly armed with information, but it was just like a tip of the iceberg, and maybe getting your tip of iceberg a little more exposed were the ocular response analyzer and now the Corvis, which has seemed to have evolved. And this is again an ultra-fast Schleimpfung imaging device, which works on the principle of a non-contact tonometry, wherein an air puff applanates the cornea. And if you can see, when you compare a normal and a post-LASIK eye, the applanation event is so significant in a post-LASIK eye because of the loss of elasticity and the elastic recoil which is lost, and how the amplitude of oscillation is so much more in post-LASIK, which is detected in very many ways in the Corvis measurements. The 6 basic measurements are the intraocular pressure movement measurements in the different stages, and the pachymetry, which is again, there are 6 of them. Going again into this, the different things which you would understand when you look at a normal LASIK and a post-LASIK eye is it tells you about the velocity of the amount of impact, the velocity, corneal velocity of how much it would applanate and recover its normal status. It will tell you about the applanation length. That is, in a normal eye, it would need more force for it to applanate as against a post-LASIK eye. So the applanation length in a normal eye would be lesser than in a, more than it would be in a post-LASIK eye, because in the post-LASIK eye, even a least impact would have it going applanating and rebounding. And again, the other very important factor which you need to look at is the deformation amplitude ratio, which compares the deformation in the central area and compares it to 2 millimeter paracentrally, and tells you the amplitude of deformation in the center or the focal area where the weakness is most important. Then these are the different graphs which are represented. I would want us all to go back with absolute basic understanding and not get more confused and muddled. What we need to know is the deformation amplitude, applanation length. As I keep saying, the applanation length would be small in a post-LASIK eye because it needs very little impact, a little applanation to get deformed. The deformation amplitude again would be far more in a post-LASIK eye, where the elasticity or the tensile strength of the cornea is lost. The velocity of deformation naturally would be more in a softer eye, and the inverse corneal radius would be more. Inverse corneal radius is 1 by r, and if you try to understand that the deformation, the curvature which happens, I think it would be too much for you all. What you need to know that in 1 by r, inverse of radius of curvature would be more in a softer cornea as against a normal cornea. So if you compare these two graphs, if you just look at the shape of the graphs, you would understand that compared to the red marks the deformation amplitude or the corneal velocity or the applanation depth, and all these factors would be more in a post-LASIK eye as against a normal eye, excepting the applanation length, which would be more in a normal eye. Again, the Vinciguerra screening report tells you how much, gives you 2 standard deviation above and below the normal range, and in a normal eye, the gray lines are the standard deviations 1 and 2, and the red indicates how much it is still within the normal range or not. And if you look at the keratoconus eye, you would realize that it is way beyond the 2 standard deviations, and that gives us some information that there is something significantly abnormal here. So these are the major 5 parameters which you need to understand, and all these are summated and a corneal biomechanical index is evolved. And then combining the parameters from the pentacam topographic data, the Corvis biomechanical data are put together, and then the TBI is involved, which is a tomographic biomechanical data. To arrive at this, the Ambrosio and Vinciguerra, what they did was they analyzed 850 eyes of 778 patients, divided them into 4 groups. One had a normal eye, one had an asymmetric cornea of a keratoconus eye, one had an eye which was keratoconic, but the other, not the eye which was, it was like a form fristic keratoconus as against an eye which was actually had intacts and surgery, and again an asymmetric cornea of a normal eye. So they just took one eye from different groups of patients and grouped them together, and then went on to analyzing, getting this formula and putting in statistical understanding, which is a random forest test, and finally they came in with the tomographic biomechanical index, and they found that compared to the Corvis biomechanical index and the BAD of the pentacam, the tomographic biomechanical index was statistically significant and had a value. Simplifying it a lot more, this is the information given by the Corvis, and this is the information given by the pentacam. If you look at these bars, we all know green is normal, orange is suspect, and red is in the danger zone. So when you look at it, this is a normal cornea. All the CBI, the BAD, and the TBI are in the green. So any of us can just look at it and know it's normal. Now then, when you look at the second eye in a form fristic keratoconus, all are in red. So that's even equally clear that yes, as far as you trust the Corvis and the biomechanical understanding which it projects, you understand that this is normal. Now, if you go back to these topographies, the pentacam, in this eye, excepting for a minimal inferior asymmetry, not even that significant. It is all quite normal. The corneal thickness, all the values are quite normal. The Bellin amblyosio is quite normal. And then you look at the Corvis, it correlates with it. Everything is, the CBI is normal, the BAD is just into the orange, but the TBI is red. So then you have had a pentacam which looks utterly normal, and your Corvis and BAD are normal, but the TBI is abnormal. Do I just cancel out this patient with the limited understanding these machines give? This is the first thing you would think. You would realize that as of now you still rely on pentacam. Maybe this would be just an added guide based on the refractive error and added on whether you would combine it with cross-linking when you're doing laser vision correction. But when you immediately go and do the left eye, the pentacam shows you a typical decentered keratoconus, and then naturally the Bellin amblyosio is bad and the tomographic index is bad. So in this particular situation, it tells you, clues you that the one eye was bad, and that is why probably the TBI was showing you in red, which was trying to make you understand that there's something wrong inherently in these eyes. So probably towards this, Corvis takes you forward. Now again, this is an eye which had a very thin cornea and a high refractive error. The corneal thickness was 464, and again the topography and the Bellin was quite normal, and the topography and the Bellin was fairly normal, the left eye too. But herein again, the TBI and the CBI and the BAD is not out of normal range. So it definitely again makes you think it's a thin cornea, and Corvis is also giving me this added information that things are not very comfortable and going. And but the refractive error incidentally to me is beyond 460 or not. I wouldn't treat a -5 or a -6, assuming it was sitting at -3 with this kind of a Corvis information. I would wonder why not I cross-link this eyes, but yet having spoken to you very briefly about Corvis, just given you a very flimsy bird's eye view of Corvis, I would still feel that Corvis, as of now, would continue to be an added supplement to sort of re-strengthen our understanding of the whole thing, but it's just a one step closer to unraveling the mysteries. But it is not something bang on which tells you that if it is in the red, no, you don't take the patient up at all. Thank you. I hope I was able to give